What is the purpose of psychiatry? Since I recorded my first episode about 2 months ago, I was struck by the complexity and the importance of this question to the extent that I couldn't really think of anything else or write about anything else or even record anything else for the podcasting stand. It dawned on me that maybe because we haven't answered or even asked this question properly, what is the purpose of psychiatry? Is that we became a field that is frequently the target of criticisms, like saying that we're medicalizing the human experience. Maybe because we don't know what the purpose of psychiatry is, or we haven't asked the question, that we ended up defining disease based on the availability of alleged treatments, like we saw an expansion in the diagnosis of bipolar disorder, going from 2% prevalence to maybe 10% prevalence in the United States. The same happened to ADHD. Now we have a per capita consumption of stimulants in the country that is 10 times more the ones of Germany, UK, and France all combined. But as I said in my first episode, I was in over my head. This question is too relevant to be answered by a crazy guy in Rhode Island. So I got some heavyweights, and we're going to turn this into a series. And Paul Andrews, that you guys already know, that was here before, is helping me with it. But before I introduce my guest, both my guests for today, I want to tell you a story about an email that I received as a response to my first episode. Someone emailed me talking about the topic, and what I understood from what this gentleman was trying to say was that the purpose of psychiatry is to amplify reality. And I thought that to be just brilliant. I was absolutely excited with that input because, in one hand, goes in the same line of the purpose of psychotherapy, that is to unveil the truth, so amplify reality. On the other hand, it contrasts with what seems to be the purpose of psychiatry as it is right now, that is, if anything, the opposite, suppress our experiences that are most likely a response to our reality. And the funny part is that that's not what he was trying to do. What I understood as being cryptic was actually an effort to be polite. And this gentleman, very intelligent, very articulate, he was a activist of the anti-psychiatry movement. And what he was actually trying to tell me is that I should quit psychiatry and get a real job, like a hairdresser or a construction worker or something like that. But I was so appalled by his insights that I couldn't even feel offended. I felt just grateful for his email. But without further, I have with me today Dr. Andy Thomson and Paul Andrews again, gladly. So I think I'm going to start with Andy. Do you mind introducing yourself? Tell us, where do you work? What's your formation? What do you do? What are your areas of interest?
Again, my name is Andy Thomson, and I'm a psychiatrist. Currently, I am at the University of Virginia Student Health Center in the Division of Counseling and Psychological Services. I've been there probably 25 years, part-time. I also had a private practice, and I retired from the private practice a couple years ago, and am now just at the counseling center and see primarily young adults 18 to 24 years of age, but also because there's a large graduate school presence here and a large professional school presence here, I will see my patient range still is up into the late 30s, early 40s. And general psychiatrist, I think the most important thing that I would convey is that books can change lives. A friend of mine gave me Robert Wright's book, The Moral Animal, and I discovered the discipline of evolutionary psychology, and it changed my professional life dramatically. It's through becoming involved in evolutionary psychology, Darwinian psychiatry, that I had the good fortune of meeting Paul and becoming involved in the field. And it has, again, dramatically changed how I think about psychiatry, how I think about the work, how I do the work. So I think that's probably the most relevant piece.
Thank you very much, Andy. Paul, your turn, man. Again.
Sure. Well, thank you, Rod, for having us on your program. It's been a pleasure, and I really anticipate we'll have a fun and interesting conversation today as well. Yeah, my name is Paul Andrews. I'm an evolutionary psychologist. I am at McMaster University in the Department of Psychology, Neuroscience, and Behavior. Yeah, I mean, I I studied depression from an evolutionary perspective, and suicide, and other painful feelings. And Yeah, I guess that's all I need to say about myself. I've been fortunate to work with Andy Thomson probably since the early 2000s. And It's been a very rewarding collaboration.
Amazing. Thank you for that. So, so the question that we are trying to explore here is, what is the purpose of psychiatry? And of course, hopefully we can be able to improve the formulation of this question um, and be able to identify some of the pitfalls that we have nowadays with the way we practice. So I'm just gonna say this: what should be the purpose of psychiatry? How could we define this thing in a way that would get us to have a more, I would say, gratifying medical field or helpful medical field? Because obviously our results have not been the best. And you guys feel free, whoever wants to share any thoughts in that field. Don't be as comfortable as you want. Any thoughts in that regard, Andy?
Well, I'd like to, let me go ahead and start, but then quickly turn it over to Paul, because I think when you put out that question, I immediately responded with treat mental illness. And as you know, Paul came back and said, I disagree with Andy, and I saw my mistake. And Paul laid it out, I think, in a way that I, with reflection, and as soon as I saw it, I agree. And so let's let Paul go ahead and, talk about what was in his second, or I guess his first long email, because I think he nailed it.
So the listeners understand we started the discussion via a group email, and it's impressive. It's the arguments that Paul laid during that moment were like very appalling. So if you wanna take turn, if you wanna start, Paul.
Sure. Thanks, Rod and Andy. Yeah, so I mean, at some level, I don't think the question of what should be the purpose of psychiatry really is all that complicated, or it shouldn't be all that complicated, because we have an understanding of what the purpose of other fields of medicine is, right? And psychiatry, being a field of medicine, should have a similar set of goals. So, as I understand it, the purpose of medicine is to restore and maintain health, physical health, and so analogously, the purpose of psychiatry ought to be simply to restore and maintain mental health. But the real problem is that psychiatry, for at least a century, I mean, you could say it's been an ongoing problem even before psychiatry was formalized, is how to accurately distinguish between normal mental states or healthy ones and unhealthy ones. And just to give you an example of the extent of the problem, Emil Kraepelin is, of course, considered one of the fathers of modern psychiatry from a diagnostic perspective. And in some of his textbooks, translated into English because he was German, in the early 1900s, he says something to the effect that it is nearly impossible to distinguish between the normal and the morbid psychological state. And fast forward to present day psychiatry, we still have a widespread recognition by most of the important thinkers in the field, including people like Thomas Insel and Bruce Cuthbert, former NIMH directors, as well as former writers of the DSM like Bob Spitzer and Alan Francis, that we really still don't understand how to accurately distinguish between normal and pathological mental states. And to me, that's scandalous, frankly, because it speaks to essentially a century of stagnation on what has to be the most fundamental question and issue within the field of psychiatry. What is a healthy and what is an unhealthy mental state? So as I see it, probably the first and foremost goal that psychiatry ought to be spending time on in order to achieve the goal of figuring out how to restore and maintain mental health ought to be figuring out how to distinguish between normal and pathological, diseased, non-diseased, disordered, non-disordered mental states. I'm going to pause there. I got more that I could say.
I like it.
Yeah.
I like what you're saying. I do struggle with the concept of mental health because possibly because of my training as a psychologist before. If I take, for example, Skinner's take on like behavioral science or behaviorism, the philosophy of behaviorism, we're going to end up saying that, okay, whatever you're doing is controlled by the environment or the history of the relationship with that environment, or a combination of both. And even though he was able to brilliantly actually entertain multi-causality, he was interested in finding the one or the small group of variables that were sufficient to change behavior, right? So I struggle with the concept of maintaining mental health or restoring mental health, because I would have to assume that your reaction to your reality can be actually pathological, as opposed to be a natural consequence of your circumstances and other factors, maybe temperament, genetic factors. Do you see where I'm going with it? That I don't think it's possible to define mental health in that sense.
Okay,
Are we talking? Were you talking about suffering, Paul? Are you trying to say we're trying to minimize suffering? Is that what restoring mental health is?
Well,
what framework we use?
I think I'd like to hold off on the issue of whether or not we, the field of psychiatry or clinical psychology ought to be involved primarily in the reduction of suffering. Because, well, maybe I can say a little bit about it. But the issue is sometimes suffering is just a natural response to the problems of life. I mean, just to phrase things in a way that your audience would understand, the nervous system is imbued with all sorts of mechanisms for detecting and responding to harmful stimuli. Nociception, right? I mean, and nociception in the periphery of our body is a complicated thing. And there are many different types of painful stimuli that our bodies have evolved to respond to. So the alleviation of suffering, taken in that context, right? So right now I'm forgetting about all emotional types of pain for the moment, just talking about physical pain and harmful stimuli in the periphery. Our body has evolved lots of mechanisms for detecting and responding to these things. And if we were to take the idea simply and only that the job of medicine ought to be to reduce suffering, well, then you can see that interventions that simply suppress or disrupt the pain response would be considered valid without regard to what the effect is on the organism by preventing it from responding, having an evolved response to the painful stimulus. So, as a simple example, suppose you've sprained your ankle. Now, like many people, I've had that happen multiple times in my life. And yeah, sure, I do take some pain medication when I have it. But what the effect of that is that the normal pain response without medication is that it hurts. And so I tend to keep my weight off of my sprained ankle. And that gives my ankle more of an opportunity to heal without further injuring it. Now, if I medicate myself, yeah, it hurts less, but it also tricks me into thinking that maybe I can put a little bit more weight on my ankle than I should, and it may, delay or sometimes worsen the healing process. So there's trade-offs there, and we need to be very careful in how we think about this goal of reducing suffering. Now, I've talked about it in the periphery, but the same is true about all the sorts of emotional pain that we experience largely through the central nervous system. And we have, again, a whole slew of painful feelings that have been imbued into our nervous system, arguably by natural selection. You can think about the pain of hunger, right, which is all mediated through, of course, your brain. The pain of being sick, the pain of what is it? Sensory perceptions that are like bright light that's too bright that can be painful. Tastes that are painful because they're too disgusting. Loud noises that become too painful. Then you've got all the emotional pains, the emotion of jealousy that's painful, anger is painful, fear, anxiety, various types of panic and phobias. And of course, the things like I study, depression as well. But we could throw in, regret, remorse, all of these painful feelings, and the wide variety of them speaks to the fact that natural selection imbued them into our nervous systems. They're not there for random reasons. And if we simply take this perspective that we should be reducing suffering without thinking about what the function of these painful feelings are, then we can be making mistakes analogously to the what we were doing when we medicate somebody who's got a sprained ankle and thereby interferes with the normal care that they would take, keeping their weight off of their ankle. Presumably, medication of all of these other painful feelings in order to reduce how their distressing nature will have negative consequences. So,
those negative consequences would get us where? I wonder if we can, in the field of psychiatry, if we can abstract what those consequences would be. Like continuing on the same analogy, like we know, for example, that chronic opioid users have more joint problems, right? Makes complete sense. We all walk funny. Every step is different from the previous one. It is as if you were inducing a diabetic foot in all your body. So because pain doesn't matter anymore, you end up having more orthopedic problems, like more joint problems. If we translate that same thought into psychiatry, what will be the long-term consequences? Taking, for example, depression and anxiety as a result, if we were just trying to suppress those experiences with meds, what will be the long-term consequences of it? And I'm asking because I have hopes that if we entertain what the long-term consequences are, we can say, well, then the opposite of psychiatry should be to foster the opposite, maybe. I don't know. I'm just exploring the idea. What do you guys think could be the long-term consequences of just suppressing emotional pain?
Yeah,
Well, I can
I'd
give
like
you,
to.
I can,
Oh yeah, I'd like to give a stab to this, but then I wanted to pass it off to Andy because I think he does have some examples of this from his practice that are useful. Um, what I'd like to say is we actually know quite a bit about painful feelings, the evolution of them, and their evolved functions. In fact, they all seem to be involved in what a psychologist would call avoidant learning and avoidant behavior, right? If you go back to, your intro psych days and you think about classical conditioning and, for instance, it's all based on the idea you expose the animal, human or rat or pigeon or whatever, to some sort of painful stimulus, right? And you essentially are trying to train it to associate some event in the environment with the painful thing so that it then learns to try to avoid the painful stimulus. And so avoidant learning is actually fundamental to all painful feelings. It's also, as an example to the sprained ankle, the pain of the sprained ankle tries to it motivates you to keep your weight off of your ankle so that you avoid hurting it further in the future. Painful feelings like depression and anxiety, or shame, disgust, guilt, etc., they're all about trying to avoid something that is harmful in the environment. The painful feelings differ in what that thing is. For instance, how you go about avoiding an infidelity that is motivated by your feeling of jealousy is going to be different than how you the way in which you are motivated to avoid starvation, which is produced by your feeling of hunger. Nevertheless, they're both integrated by this idea of trying to avoid something harmful. So Andy and I have been working for about 20 years on this particular idea with respect to depression, that the thing that depressed people are trying to avoid is some sort of complicated problem with some untoward consequences. And of course, that problem may differ between individuals. So, but an example might be somebody who's depressed because their partner is wanting to divorce them. And if they don't want to be divorced, and the divorce would cause all sorts of complicated issues in their lives. And so the depression motivates a type of cognition, which we call analytical or type 2 processing, which marshals their full intellectual powers to try and solve that complicated problem. Anyway, but again, I want to just stick to this idea. Avoidant learning, avoidant behavior is this fundamental thing that integrates all painful feelings. And so just that as theory, I'd like to then pass it off to Andy because I think he's got lots of really great examples.
let's stick with Paul's example. Let's say that Paul, during the week, his ankle feels sort of okay, but on the weekends when he tries to take some time off, he goes out for a walk and, the ankle is still hurting. So he goes to a physician, and the physician diagnoses him with major ankle pain recurrent, moderate, and just gives Paul Tylenol and sends him on his way. And so he takes a little Tylenol, and the thing recurs again. And so 2 or 3 weeks go by, and Paul has ankle pain, particularly on Sundays and Mondays after he goes out for a walk. And he goes back to his physician, and his physician says, it's major ankle pain recurrent, getting worse. And ups his Tylenol dose or gives him a stronger pain medication and doesn't bother to look at the origin of Paul's ankle pain and investigate what is causing it. And that's basically the situation we're in psychiatry. And I think all psychiatrists listening to this are medically trained and they don't see this. How would they see that family physician who kept diagnosing Paul with major ankle pain recurrent and just manipulated medication without looking at the causes of Paul's ankle pain and understanding that the pain is an evolved signal? And I think that's the situation we are in big time. And let me give you some more examples. Let me just give you, 3 brief examples, I think, that illustrate this. So I saw a patient, a middle-aged woman, and she'd been put on Paxil for her depression. And she told me that, yes, she felt a whole lot better. The Paxil had made her feel a whole lot better, but then she paused and she said, but I'm still married to the same abusive alcoholic man. And I think the previous people that had treated her, didn't look at the fact that her misery, her depression was she was in a very painful, complicated situation. She was married to an abusive alcoholic man on whom she was dependent for financial support for her and their children. So the decision to initiate a divorce was a very complicated, difficult one. And again, she's talking about pain that she had, psychological pain, for very good reason, that just got medicated away. Let me give you one more example. And I see these examples all the time. And I would ask the psychiatrists that are listening to this to step back and to think about their own practice and their own patients and see if some of this resonates. So, first year graduate student in one of the toughest professional schools we have here at the university comes in beginning first year of the graduate school and engaged to be married. And literally the week that the individual is starting this very difficult graduate program, fiance abruptly ends the relationship. It's over and don't want to talk to you again. Needless to say, this individual is devastated, utterly devastated. And a very complicated situation, had made significant changes in the individual life to accommodate the relationship and the plans moving forward. Utterly devastated, appropriately, but trying to start this incredibly difficult graduate program. So goes to the dean of students in that particular school and to try to see if, what the individual might do. And the dean of students literally hammers the individual about, you need to be on medication. You need to get on medication. And it also saw a therapist. And the therapist was pushing meds, unfortunately. And it was very difficult trying to get across. And the patient thought that there was something wrong with them, that they were in such pain. And it was very difficult to get across to the patient, to the therapist. I didn't talk to the dean of students for confidentiality reasons, that this was a perfectly appropriate reaction. And the person was in agony because they had built a life on the plan going forward. And it was heartbreak. It was the, the verses of country western music right there. And it was seen as an acute major depression that needed to be medicated. And instead, what was called for was support, some accommodations, and helping the person sort through, okay, what are we now going to do? What are we going to do going forward? How are we going to, get through these first, difficult weeks of the graduate school? How are we going to accommodate to the loss of this crucial relationship? Informed treatment, and it's treatment and it's therapy, but it's not based on that there's something wrong or sick about the individual. They've got a devastating loss. So let me give you one more case that I think illustrates the problem. And so this is an individual who's about to graduate and is going to be graduating soon. And the individual comes in with anxiety and a little depression. And the prominent symptom is anxiety. And the therapist is completely focused on behavioral strategies for managing the anxiety, giving them breathing techniques, giving them various techniques to deal with the symptom, and not looking at the source of the anxiety. Refers to psychiatry for medication. And the psychiatry resident, and I know about the case because it's somebody that I supervise, the psychiatry resident is, again, going through a DSM checklist and saying, well, don't quite meet the criteria for generalized anxiety disorder, so no medication. What's fascinating about it is that both individuals, the therapist and the psychiatrist, in their histories had what I would argue were the reasons for this individual's anxiety and depression. The individual was gay. The family was that they came from was intensely conservative Islamic. Homosexuality is illegal, a sin. And the individual has been living a lie with their family for years. And one of the parents has a potentially terminal illness. So you could, and they didn't bother, even though it was like they had their hands on the crucial material that would explain the patient's anxiety and depression, but they're caught up in checklist DSM criteria, and they're just sort of managing symptoms without going at what's causing the symptoms.
It's just perfect. I want to retranslate these things you said, because when Paul goes to the doctor with a bad ankle and the doctor diagnoses with major ankle pain, that's a syndromic diagnosis. It's not an etiological diagnosis. And the surprising part of it is, in our field, a lot of people coming out of training, doesn't matter if he's a psychiatric nurse practitioner or a psychiatrist.
Right.
Psychiatrists like to believe their training is better. But they are coming out of training without realizing that the whole DSM, with exception of one or two diagnoses, are syndromic, and they are equivalent of major ankle pain without an exploration of the causes. So that is one thing I wanted to say. The other thing that I'm starting to feel is that maybe the purpose of psychiatry at this moment would be to protect patients from the current modern psychiatry. But I want to...
The purpose of psychiatry is to protect patients from DSM.
There you have it. That would be a good one. Or or give DSM the place it should have as a billing tool. Finally, or the place that it earned, unfortunately. But why do you think we are not? Obviously, we're going to go over the financial interests behind it, but how come we became, I'm going to call, forbidden of establishing causation in the relationship of the individual with the environment, as opposed to this imaginary biochemical brain balance thing that it so has been on vogue, and I have the feeling it's starting to die. But how come 100 years of production in the field of psychology became ignored, and it was excluded from our practice? How come saying, hey, and I go one step further, because one thing that I see in my mentoring institute and with people that I supervise is when I say, well, why is this patient depressed, when they're running cases by me, right? Because I work with supervision a fair amount of hours per week. And they say, well, because he has depression, right? The usual tautology. And I say, well, no. Let's understand depression as a verb. what is making this patient depressed. And what usually people are looking for are very evident stressors. So then I make an effort to show them that even the American dream, someone who, and I frequently say that the white Americans are the meat going through the grinder of financial interests. All ideological propaganda, all pharmaceutical propaganda is targeted at white Americans for obvious reasons. They historically have been the ones capable of affording these things. So when I say, or the same happens with patients, and I say, well, why do you think you could possibly be depressed? And the answer is, well, there's no reason for depression. They have the house, the spouse, the car, the job, the kids. There's no reason to be depressed. There's no evident problem. And then you go like, well, how long has this person been living this very same life without novelty, without further accomplishments, without any challenges? And we can take different angles. I really like positive psychology, the PERMA acronym for, to generate positive emotions, you have to do the things that generate positive emotions. You have to be enrolled in life. You have to have achievements, a sense of purpose and meaning. And I feel that people just cannot see beyond the acute stress or acute stressor level. They don't realize that we're not designed for 20 years of sameness. We're not, even boredom per se may be a reason for desperation for some people. But I guess, why do you think how do we ended up here? How did we just ignore all the geniuses we have in our past and said, yeah, it's something in his brain. Let's call it that and move on. Go for it, Paul.
Yeah, it's a great question, and I have some things to add to this, but I think again, Andy, has a lot that he will be able to say about it too. So, I actually do think that the DSM-3, written by Bob Spitzer, which sort of revolutionized how purported mental disorders were diagnosed, is somewhat to blame. And it has to do with the fact that was sort of like the origin of the idea that I think we now know as the clinical significance criterion in the DSM. The clinical significance criterion is essentially the statement that a trait is a mental disorder if it causes clinically significant distress or impairment. In fact, of course, that's within the DSM. The DSM acknowledges that what they're really trying to get at with the diagnosis of diagnostic criteria, they're trying to accurately distinguish between healthy and pathological mental states. And so the DSM since 1980 has variation of a statement that whatever the diagnostic criteria, the essence of it is that there must be some dysfunction in either the brain or some area of functioning. But then the DSM, I think, has fairly consistently said, we really don't know how to identify dysfunction in the brain. And so we're going to use a proxy for defining something to be a mental disorder. And that proxy is essentially the clinical significance criterion. The DSM has in the absence of the ability to accurately distinguish, we're going to use the idea that if a trait is causing clinically significant distress or impairment, then we're going to treat it as a de facto disorder. Okay, so this is, arguably a humane and honest attempt to deal with the problem. It's first of all, it's honest because they admit that they don't know how to accurately distinguish between functioning and dysfunctioning psychological states. And it's humane because why wouldn't you want to alleviate suffering, right? Okay. But it is essentially, I'm going to use the word a seductive red herring. And that's because in every other domain of medicine, etiology is fundamental to understanding how to diagnose and how to treat. And with the clinical significance criterion, it essentially gives psychiatrists permission to ignore etiology. Why? Because, as we've already talked about, if the goal is to alleviate suffering, then you can ignore the reasons for the suffering. You can ignore those causes of suffering that are the result of normally functioning nociception or pain mechanisms, or the ones that are caused by dysfunctioning or malfunctioning nociception pain mechanisms. And, I've often heard it said, it didn't come from me, but it came from other people in the field of psychiatry and critics of psychiatry, that sometimes psychiatry is considered the black sheep of medicine. And I think that is one of the reasons for that, is because they really don't have a good handle on etiology. The syndromic nature of all of the conditions that are discussed in the DSM really often does ignore etiology. It doesn't separate out normally functioning and dysfunctioning pain mechanisms. And so, yeah, I think the clinical significance criterion gives psychiatrists permission to ignore etiology. And by the way, it's also something that the pharmaceutical industry utilizes as well. There's this great book by, I think it's Cassells and Moynihan, called Selling Sickness, published in 2005. And at the very beginning of their book, they point out a Reuters Business Insight article that was published that basically said that the goal of pharmaceutical industry, or many pharmaceutical companies, is to try to convince people and lawmakers, psychiatrists, etc., that many of the ills or ailments that people have are actually medical problems that require treatment. And of course, for instance, as one example of this that I think they're still going on, is they're trying to convince people that when problems with women getting sexually aroused is essentially a mental disorder or of some sort that requires treatment, and therefore so they're searching for a female version of Viagra, right? I don't know if they've found one yet, but it's long been known that there's just lots of natural variability in women's sexual arousal, and that part of that also seems to be situationally dependent, like on the quality of the relationship, and it has nothing at all to do with something going wrong in the female nervous system. But again, the clinical significance criterion, whether focusing on distress and or impairment, gives everybody permission to ignore etiology and say we've got a problem that must be treated. Okay, I'm done with my spiel.
Very cool. And did you have any on that?
Yes, I think Paul's identified one of the most important things, which is psychiatry got a sort of diplomatic free pass with this clinical significance criteria that is one of the additional things, one of the main things that allows psychiatry to not have to pursue and understand etiology, causation. And again, I want the audience to think about it, because I just don't believe our profession clearly sees it. How would you look at an ER doctor who had a patient come in with chest pain, and they kept coming in week after week with chest pain, and they were just given nitroglycerin? And the person is diagnosed as, major chest pain recurrent, moderate, seeming getting worse, and they're just given nitroglycerin, and nobody bothers to do an EKG. Nobody bothers to see what the cause of this chest pain is, and particularly to see if the cause is a coronary occlusion, which could potentially be lethal. That's the kind of situation we're in psychiatry, and I don't think the profession wants to acknowledge that. How we got here, what Paul said, the clinical significance criteria giving us a free pass. I also think there is, if you go to that Tooby and Cosmides article that Paul sent, the 1999 article, they've got an interesting, it's really buried in a paragraph in there, that the history of medicine is that when we didn't know the cause of something, we classified things in symptom clusters as a way of trying to deal with it. And then as causation is known, things shift. And psychiatry is still stuck in keeping things classified in symptom clusters and not pursuing etiology. It would be one thing if those etiologies were undiscoverable, but I think we're now in a situation where the etiologies of a lot of these things the etiologies are known, but we're not paying attention to it. And psychiatry is very proud of the fact that they threw out Freud. And that's part of a broader picture they don't want to acknowledge, I think, which is they threw out psychology, or they kept walls between psychiatry and psychology. And they particularly have walls with evolutionary psychology. And then you have, at least in my career, they pushed psychiatry out of doing psychotherapy. And so that led psychiatry to become even more focused on psychopharmacology and claiming to be, in a sense, based in neuroscience. But again, as Paul pointed out in that email, that they got focused on neuroscience, but skipped some crucial steps. And the crucial steps, putting the neuroscience discoveries in the context of evolution, that the mind is what the brain does, and the brain is just as much an evolved organ as the heart, and it has systems that are functional. And I think that's where that's part of why we're in the complicated position we're in. I think it's multifactorial, and it also includes, as you pointed out, the pharmacology and the pharmaceutical industry trying to medicalize defense mechanisms and medicate them. I mean, it's just a host of factors. But I think the crucial things are we've been given a diplomatic free pass about having to keep pursuing etiology and incorporating our understanding of etiology into our treatment approaches.
Go ahead, Paul.
Yeah, I know Andy's so good at coming up with really good analogies that help make the point so clearly. I'm really grateful that Andy's here today. Just to follow up what Andy was saying about studying the brain, but without really appreciating that it's an evolved organ, and that the evolutionary lens can really be helpful in helping us understand what the brain evolved to do. This is essentially a point made by Thomas Insel and Bruce Cuthbert when they were directors of the NIMH, and they created RDoC, the Research Domain Criteria. One of the explicit goals of RDoC is to identify the evolved functioning of all functions of the brain. It's and I know that RDoC is sometimes, by many people, is viewed as somewhat controversial. But again, here is an explicit attempt to say we must understand how the brain evolved to function, and it's meeting resistance within the field. So I'm not saying I agree with everything about RDoc, but that clearly represents an attempt to move forward in a positive way.
Yeah, and I think in general, every time I can speak from my personal experience that I left my residency training, and as you're supposed to do, residency medical training is not only medical training, is also a test of compliance, right? Because you have so little time for so many questions. Doesn't matter how many of those questions are related to castles that are built in the air. So I left my training, and I was a very inline psychiatrist, and I would repeat all those maxims and practice psychiatry like everybody else, and I would make diagnoses based on pretty much checklists. And as I started to notice that something was wrong, first I hesitated for a long time to even share those ideas, because when you do share these ideas, when you take the risk of saying, hey man, what if all that suffering has a function and we should just let it sit and help understand or amplify reality to the patient so he understands where it's coming from, like that gentleman emailed me, or I thought he did. But what happens is that you find you pose as a charlatan. When you use that kind of logic, somehow the field is such that when you use that kind of logic, or as much as applying philosophy to psychiatry, you are the guy selling snake oil, not everybody else that has been saying, oh, you're depressed. Well, you have a perfect life, and you should be happy. No negative emotions for you. It's some problem in your brain. We didn't find it yet, but we're going to call it brain disease. And those are the serious guys. And if you start questioning these things, you're selling snake oil, and that stuff. So it took a lot of guts for me to start the podcast, and I started very smoothly. And gradually I said, okay, I think I can become more daring with this thing. But people that talk like this, they are usually not very vocal. People that are seeing these things, they kind of talk on the side. They talk, there is no openness to debate in the field. The other thing I want to point out that I think we are talking a lot about that may help us guide our conversation towards the main question, what's the purpose of psychiatry, is that we have had many analogies with pain, right? And I think we could go and say, what is the purpose of suffering? What is the goal of each sort of pain that we have, that we feel? Because if we understand what the goal of pain is, the goal of suffering, why did we, and I know I'm implying a purpose to the suffering as opposed to be, a consequence of natural selection, or for the creationists out there. The Bible is full of references that human beings were born to trouble, and we are here to experience the world. We are the salt of earth, on Jesus' own words. The reason I cover that is because just to make sure that despite coming from different places, we are going to the same place. But what is the purpose of suffering? Why someone would have a chest pain when he's having a coronary occlusion? Why someone would have an ankle pain when there's something wrong with the ankle? And then we can maybe make an analogy with psychiatry, and if so, then the goal of psychiatry, the purpose of psychiatry, would involve respecting that, as opposed to just suppressing, as we have been doing.
Yeah. So I think we've already started touching on the what in evolution we would call the function of suffering. But I just want to give a call out to your analogy. I mean, I want about snake oil. I think another way of saying what you've just said is that the standard of practice within psychiatry has been to sell snake oil, or is to sell snake oil. And if you're not interested in selling snake oil, then you're viewed as a whatever, wacky or something like that. So again, I think the function of suffering that we've learned from evolutionary biology, it's and it's broad. It's in the studying human emotion, various forms of human emotional pain, as well as pain in non-human animals. There's a woman in Great Britain named Lynn Snedden who's done some great review articles on pain in fish and other aquatic animals. And the criteria that we can use to identify whether or not other animals do feel pain. And it's some brilliant work. But again, at the core of this is that painful feelings evolved in response to some sort of harmful stimulus, and that the function of the pain mechanism is to help the organism avoid something harmful. And there are a number of examples that we can give. I'm going to start off with a wonderful paper by a researcher. I think she's in California right now. Her last name is Crook, but it's on whether or not squid feel pain, and it essentially has to do with the following. So the squid, they have a whole bunch of squid, and the natural predator of the squid is a sea bass. So they randomize the squid into a 2x2 experimental design where the squid are either injured or not injured. By injured, they clip off one of the tips of one of the tentacles of the squid. And the other dimension of this 2x2 is whether or not they received an anesthetic. Okay, so you have squid that have been injured and not injured, and also squid that have received an anesthetic or not. Then they put the squid into a tank with a sea bass, and the tank is large enough so that they can move around, etc. And they monitor a whole bunch of things. The crux of the experiment, however, the results are that the injured squid are more easily they're targeted by the bass. Somehow the bass can determine that the squid are injured, and so they preferentially target injured squid. And so it's bad to be injured, that's for sure. Secondly, it turns out, though, that the injured squid who are unmedicated, who have not received the anesthetic, take extra precautions. They try to take evasive maneuvers sooner, before the bass gets close, than the injured squid that have received the anesthetic. And in the end, it turns out that the injured squid that have received the anesthetic are captured and eaten at a greater rate than the ones that are injured but unmedicated. It's actually a powerful demonstration of the value of having a painful feeling in an evolutionarily relevant context. Okay. And you could, in principle, analogize the use of the anesthetic here in terms of, the suppression of painful emotional feelings like depression and anxiety. What can we say about that? Well, again, our perspective is that depression promotes a careful analytical, in psychology we call it type 2 processing style, which involves working memory. So it's this type 2 analytical processing style is very useful for solving complex problems. And philosophically, you might imagine or predict that to the degree antidepressants are effective in reducing symptoms, obviously there's some debate about how effective they are in reducing symptoms, but they do seem to be somewhat effective. You'd probably expect that they would interfere with the ability to produce that type 2 analytical processing style. There are indications that that is happening. For instance, we know that cognitive behavioral therapy seems to have one advantage over antidepressants, at least in the after the treatments have been discontinued. So after discontinuation of antidepressants, there's no evidence that they prevent recurrences. In fact, people who've been on antidepressants may be at an elevated risk of a recurrence. But people who've been on CBT, pure CBT, tend to have a lower rate of recurrence than people who've been on antidepressants. And one of the arguments is that, the CBT may help you think through the various aspects of your problems, and that may be part of the therapy or therapeutic effect of CBT. Okay, but we also have now a study done by David Barlow on, I think it's panic, where they had CBT, antidepressants, CBT plus antidepressants, and placebo. So actually, I think maybe I should say it again. It's antidepressants without CBT, CBT plus placebo, the antidepressants plus CBT, and CBT or placebo on its own. So it's actually a well-designed study. And what they found in that is after treatment was over, they were looking at the risk of recurrence of the panic disorder. And they found that the pure CBT had a lower risk of recurrence than the antidepressants. But when you added antidepressants to the CBT, it had the same risk of recurrence as the antidepressants. Put another way, it looks like that the antidepressants were interfering with the whatever cognitive benefits that were being received by the by CBT. And we've got a number of other indications, and I think you might be able to help us with some of that yourself, Rod.
We already know that, for example, with benzodiazepines, which is the most blatant example, if you have someone with a phobia and you're doing exposure therapy and the patient's taking benzodiazepines, the learning necessary doesn't happen. So benzodiazepines, in a sense, they're going to curb the results of and from a clinical perspective, it translates in a question like this. For example, someone comes to you and says, "Doc, I have to fly. I'm afraid of flying." And from a clinical perspective, you're going to say, "Well, how frequently do you need to fly?" It says once a year. There'll be no exposure there, right? So there's no exposure there. And the suffering that you have by flying an airplane, yeah, I hate flying too, right? So here's your drug, pop it, flies fine, come back, and that's it. Because if I just let you fly once a year, knowing what we know about exposure, the suffering is not going to justify itself. There will be no learning. There's no exposure enough to make a meaningful dent. So then, you know what? Enjoy your trip. An advice that I would give people if I wasn't bound by ethical concerns is to say you can also alternatively have a few shots of tequila during the flight. The impact is going to be very similar. And, some people consider alcohol much safer than benzodiazepines and so forth, so on. It's also much more fun. with antidepressants, we have had people in the field for the last 20 years or more saying they're just numbing agents. They're really taking out the low, but also cutting the ups, really reducing amplitude of emotional experience to some extent. And if that happened, and now we are seeing more of this, in the clinical practice, we see that daily. In clinical practice, people come and say, well, I tried this made me feel blah, made me feel numb, I couldn't feel anything. Sort of an induced anhedonia, but I didn't care too much about it because sex didn't have any taste anymore, food didn't have any taste, going out with my friends didn't have any taste. But maybe in that moment, I always defend antidepressants, even though I rarely prescribe, because I have a take in my clinical. So far, I have been focusing on quality of life. So I prescribe more Viagra than antidepressants, to give you an idea. But I refuse to believe that numbing emotions has no function. It may come to be that SSRIs are the worst options we have to numb emotions, when numbing emotions is the only option available for someone to follow a given goal that I'm still not clear what it is. Improve quality of life. I like general terms that that can give to my listeners guidance. So for example, I like to say maybe the goal of psychiatry should be to foster movement, just like pain fosters movement, in the sense of saying whatever you're doing, you need to do something differently. If you right now we're sitting for about 1 hour now, and your buttocks starts hurting, so it fosters you to kind of switch the weight and move a little bit, and we know that that's a big deal also in nursing homes, right? So suffering fosters movement, fosters change as opposed to stagnation. So yeah, we do have a lot of reasons to believe that any emotionally numbing agent, from antidepressants to antipsychotics, benzos, you name it, mood stabilizers, would have a stay put impact, would have a impact on your ability to learn as well. There's a paper already showing that I think was Celexa, impairs consequence-based learning in healthy subjects.
That's avoided learning.
Yeah, because we have been hearing people complain in clinical situations that they became impulsive with antidepressants, right? You don't care about the consequences anymore. That would be a way to translate, not caring about something adversive that can possibly happen. So, and we have a guy like Robert Whittaker that is like, considered heretic in the temple of psychiatry. That says that his belief seems to be that our rates of disability increased along with our rates of prescribing because of the prescribing. Not only that, the prescribing is not helping. He says the prescribing is causing all this damage, the disability rates due to mental health. And, and I think there are more factors there. And, a fair percentage of being correct, could be attributed to that statement. But there's other factors as well. Just the fact that culturally, it's very attractive. It's sexy to have bipolar. Culturally people say, oh, stigma. Yeah, we still have stigma for a few diagnoses, but some of our diagnoses became sexy. ADHD is sexy to have ADHD, sexy to have bipolar. I have seen teenagers crying when the diagnosis of autism was removed, because it became such an identity that back in the day you could just be a weird person. Now you have to have a diagnosis. You cannot be just a weird guy, right? But yeah, sorry, I digress. Yes, we know that meds, we have enough reasons to believe that meds are impairing learning. We know hard proof that they have cognitive impairment. We don't, and we have enough to believe that they are probably holding people back, just like the case that Andy gave an example. I'm still in the same miserable situation I was, but somehow I'm not suffering as much anymore.
I wanted to go back to that actually, because I think if I remember the story correctly, Andy, this woman actually was wanting to go off of the Paxil when she came to you, and you had said, well, if the drug is working, why is it that you want to go off? And her answer was, as you gave, she's still married to the same abusive alcoholic man. And so she had this awareness that her pain was motivational for her to change her behavior, as you were saying, Rod, and that it served some useful purpose, and that's why she wanted to go off. Yeah, Andy, do you have more to say on this whole point?
Yeah, I think sometimes our patients are smarter than we are. I think go back to Rod's question about suffering. I think you want to think about it like Apollo 13. Houston, we got a problem, right? And pain is nature's way of telling you got a problem and motivating you to stop business as usual and to try to find the source of the problem and to fix it in humans. And there's utility. And I want to put I think Paul is being modest here because the Disordered Doctors paper, Paul, in essence, has laid out a theory of depression that is consistent at every level, from molecules all the way up to minds. And I think that particularly the psychiatrists in your audience, the physicians, want to pay attention to this, because one of the most beautiful examples is what happens to physicians who have made a serious error, injured or killed a patient. They get depressed, and they get at times very depressed, and they meet the criteria for major depression. And the evidence is that the physicians who get depressed are more likely to make corrective changes in their practices. And I think all of us know this intuitively. What would we think about a physician who made an error that killed a patient, and they just blew it off, and they blame the hospital or they blame the anesthesiologist? All of us would go, whoa, wait a second. This guy is not learning from his mistakes. So we intuitively know this. And the physician who takes responsibility, gets depressed, feels bad, stops business as usual, tries to figure out where they made the mistake, and take corrective action in their practice, the clear utility of even a very painful, miserable depression is right there in front of us. And I think the physicians in the audience ought to take a look at the paper and think about it, because they know it intuitively already in their own clinical experience with themselves if they've made mistakes, and observing other physicians who've made mistakes and been miserable, and also particularly physicians who've made mistakes and not been miserable and blew it off.
Thank you for saying that, Andy. And I guess I hadn't really thought about that paper right now in the context of our conversation, but Andy is absolutely right. And I think, Andy, I just want to emphasize something else that Andy says. That literature on the emotional responses of physicians who have made serious medical errors, indicates that the more misery they feel, the more they take corrective action to try and reduce the chances that they will make a similar mistake in the future. It's a correlation, right? The more misery you feel, the more likely you are to take corrective actions. And the implication is, as Andy also said, that without any misery, the chances of taking corrective action are very low. And we were sort of forced to take out by the reviewers a wonderful anecdote that's published in this literature, and it's pretty stunning, but it's I guess it's the is a pre-registration health officer, which is, I guess, the British equivalent of a resident or something like that.
Mm-hmm. It would be, I think, the American equivalent of like a PG 1 or 2, I believe. It was
Okay.
a resident. It was a resident in training.
Yeah. Okay. So the woman who's interviewing this, I think it's a guy based on the
Yes.
language that's used, but I don't know for a fact because at least some of the identifying information was taken out. It's still stunning that it was published, but this woman interviews this guy and says, have there been any times where you've made a serious error that's hurt a patient? And the guy goes, "Oh, yeah, I think there's this one time when my patient started tanking, and I didn't call my supervisors fast enough, and another couple of times where I didn't check results fast enough, and a couple of patients died." And in essence, this guy admits essentially to having been instrumental in the deaths of 3 patients. But then, without even any prompting, he goes, "But you know what? You'd almost like say it wasn't really my fault because I'm just a PRHO, a resident, and I'm supposed to be supervised. So it's almost as if it was my supervisor's fault." I mean, it's stunning that he again would make this kind of an admission. And then when the interviewer asks him, "Well, did you ever have a chance to reflect on this?" The guy basically says, "Oh yeah. At the end of the day, you talk to your colleagues, your friends, and yeah, But no, there's no sense in here that after having been involved in the deaths of 3 patients, that this person has any anxiety or any angst over this issue. No sense that any learning has taken place, no interest in any learning take place, and of course, no sense of responsibility, which would be crucial to all of those things. At the end of this, this interviewer, at the end of their paper, where they interviewed a whole bunch of people, but the interviewer concluded that the current emphasis on making residents feel, making to soothe any feelings of angst that they have may be counterproductive because it may interfere with learning moments, right? And so Andy's point is about when you look. Andy made this point very clear to me. It's also clear in the literature that whatever kind of physician you are going to do something that hurts a patient at some point in your life. If you're a psychiatrist, you're probably going to have multiple patients who commit suicide. And that's not necessarily your fault, but but most psychiatrists who experience a patient committing suicide will view it maybe not as an error, but certainly as a failure, something like that. So in any event, it's a similar kind of idea. And it happens. So there's no way to have a medical system that completely eliminates errors. What you want are physicians who learn from their errors. And so it turns out that the angst that they feel is positively related to essentially learning. And that goes up into the clinical levels. It's not like a U-shaped curve. It's that even people who meet DSM levels of depression and anxiety and acute stress are the ones who are making the greatest changes to their practice, right? Okay, so it's just another way of phrasing this issue about suffering.
What I'm thinking here is that, transposing those examples to psychotherapy and psychiatry right now is that we're really talking about personal responsibility, which is a core concept in psychotherapy. You can look to any psychotherapy school and with some questioning on the behaviors, because Skinner was strong on the free will part of things. He didn't based on a world of physics. In a world of physics, there's no such a thing as free will. That was his argument, right? But the person that is behaving is still the respondent, and in that sense, the responsible. But as it is designed right now, our model of disease and treatment in the field of psychiatry exempts people of personal responsibility. Because I have ADHD. It's this entity. What can I do? I have depression. I have bipolar. That's why I go in these sprees and I do stupid things. I'm very snappy because any irritability became bipolar nowadays. Having a family history of bipolar used to mean something. Now everybody has. So, and it's at the same time that is a cultural phenomena, just like with the residents. Let's try to protect these guys and let them have like a good time and be cool and kind of soothing. It kind of opens the door to this concept of brain disease where you don't have to do anything. Now the responsibility for your suffering or well-being doesn't belong to you anymore. It belongs to either your doctor, because your doctor is failing. It belongs to the pharmaceutical company that didn't make the right combination of medications yet. And patients and doctors go into this chase of this perfect combination of medications that will actually make you feel good without you having to implement any changes in your reality, without you having to pay any meaningful prices to enjoy some positive emotions here and there. So it's a very good example, and shows exactly where we are.
Yeah. I was thinking about what you were saying, Rod, about the, sometimes these diagnoses, alleviate us of the sense of responsibility. And that's, of course, always been one of the angles with respect to depression, that by labeling it a disorder, we're giving people the freedom to believe that they're not personally responsible for the disorder, right? It's something that happens to them due to genetics or something that's going wrong in the brain or whatever it is. And that's, and I understand the humane sort of motivation underneath that, but and you'd also said that some of these disorders are somewhat sexy, and I wanted to say, okay, maybe to some degree, some of them have a certain degree of, sexiness. But the thing is I still think that this idea that by labeling these conditions as disorders, we're actually destigmatizing the condition is not fully right. I mean, you think about, if it were really sexy, you'd put on your dating profile that, yeah, I've got bipolar disorder, or I've got autism, or, I've got a history of suicidal, whatever. And you see that the argument starts breaking down.
You'd be surprised, Paul. You'd be surprised. You're going to find TikTok videos teaching kids to behave in specific ways to receive a diagnosis of autism during an appointment. I'm going to tell you, man, if I were to post or to respond to every insane post that I see on LinkedIn, because at times I do, depending on how I'm feeling on the day, and of course, I incur unpopularity. But people do post these things. They do say, I finally got diagnosed with ADHD. And then everybody goes and responds to that saying, yes, like,
we have sympathy for them. But
it's more than sympathy. I have seen this thing being desirable in so many senses. Why is not happening with schizophrenia?
I mean, maybe you're right. I'm not trying to say, that I've, up to date on social media and everything, but again, I do think, look, when, if you're in the, dating pool, are you looking to date somebody who's got a mental disorder? I think not. I think that you tend to even to whatever else you've said that's true, to the degree that people take some pride in their diagnosis, are willing to post it. I don't think that people are generally out to, yeah, I want to date somebody with ADHD, or I want to date somebody who's got autism, or etc. Like also,
in that
yeah,
sense, if I use the word sex and it comes across as that, I apologize. That's not really
no,
what I
no,
meant.
but I'm trying to get at the point that there is still some stigmatization to these things, and that's also why you don't normally want to put it down in a job application either, right? Because you're worried that your potential employer will look at that and say, well, Jesus, we don't want somebody who's got a mental disorder working for us. As Andy knows better than I know, but you probably also know it too, that many psychiatrists or physicians really, really, really don't want themselves to have a disordered diagnosis. There's this case of Lorna Breen, who it's I don't know if you know about it, Rod, but it's this famous um, case that happened during COVID of a stellar, a highly, highly accomplished woman, a physician who was on the front line in a major hospital in New York City, and she ended up getting COVID, and she it was, I think, still at an early point, and she didn't understand that she was going to be knocked out for weeks, maybe even months, in terms of her ability to recover from the COVID, and she had this long-lasting fatigue that prevented her from really working up to the standards that she had been used to. And she ended up getting depressed over her inability to return to work, feeling like it was a personal failure. And she ended up, from her depression, going into a psychiatric hospital. And then things just sort of ballooned from that, because now she was worried that because she's got a record of being in a psychiatric hospital, that her, what was a fabulous career, was ruined, and that it was going to follow her around forever. And what I learned from this is that many physicians view other physicians who have psychiatric diagnoses as potentially problematic. So you really want to avoid getting a psychiatric diagnosis, especially if you're a physician. Anyway, she ended up committing suicide over this whole thing, And Andy, did I miss anything about that?
No.
Major parts of the story? Okay, so
No. And
go ahead.
And just for the audience, look it up. There's a heartbreaking article that details it in the New York Times about her.
Lorna Breen. Yeah. So, also another context in which people are completely, you don't want to have a diagnosis of a psychiatric is if you're running for some sort of public office. It's the death knell, right? If it becomes widely known that you've had a psychiatric diagnosis, you lose, you're not going to get elected for public office. And there's also, if the disorder narrative is right, it makes perfect sense. Do you want people with disordered brains in high-powered positions, like being physicians or in politicians, where they need to make important decisions, and making important decisions requires a well-functioning brain? So the disorder narrative versus normal emotional response has real important implications. I personally don't think that Lorna Breen should have had all of the stigma associated with her being depressed. But the reason why I can say that is because I think depression is a normal response to, in almost all situations, with some caveats, but in most situations, depression is a response to the problems of life, and it's a normal response. And that's why we ought not to pathologize or stigmatize people who get depressed or have anxiety. They need help dealing with those problems, and when they get those resolved, they can go back to work because they do have well-functioning brains.
Absolutely, I don't question that at all. But what I hear you saying is that despite what I call this expansion of diagnosis and this selling of some diagnoses, specific diagnoses that I referred to as sexy, right? We have a huge expansion of autism. We have a huge expansion of bipolarity. I see people in my clinical work coming seeking for those diagnoses, motivated to get them for different reasons. ADHD is obvious, besides being a pass for all our shortcomings from a career perspective, also can result in accommodations depending on where you are. But that doesn't really impact the things that you are mentioning. It doesn't really impact the actual stigma that may exist behind or related to some disorders. While for a subgroup of teenagers may be highly desirable to receive a diagnosis of autism, or because that has been my exposure to this thing, right? Nobody really talks about other behavioral difficulties that people have, like, for example, addiction to pornography. We're going to call it addiction for the sake of it now. And someone that spends all night long seeing pornography, ruins his sexual life, ruins his professional life. He doesn't talk about it. It takes a lot to talk about it. It's not like an effort is being made to reduce the stigma. It's not that. It's an effort is being made to sell a brand. And the brand that is being sold are the brands for which we actually have patented medications. So in the past decade, we saw an increase in autism since Abilify was patented for behavioral problems of approved for behavioral problems of autism. Because every kid may have behavioral problems, but if you have a diagnosis now, justifies the use of this drug. And the same happened with all the new versions of stimulants over the past decade. And the same happened with all the new antipsychotics over the past decade that are all running out of patent right now. And then you start seeing papers saying, adding an antipsychotic. There's a beautiful paper about it. Adding an antipsychotic to a medication regimen to address depression has a mortality added due to the antipsychotic that is higher than the mortality by suicide in the same population. So if your excuse to put an antipsychotic with an antidepressant was to reduce suicidality, no, your likelihood is to kill this patient with the antipsychotic more than is that the patient's going to die of suicide. And I'm talking about MDD, major depressive, people that met criteria for major depressive syndrome. And now that all the antipsychotics are out of patent, this paper comes out, and the authors are, I usually see the author and I do this search for more papers to see if they were, so that all these authors have, 100% of the authors have ties with pharmaceutical companies. That paper specifically, there are other papers, because I'm trying to make a judgment if I'm just looking to someone like, for example, the papers on Seroquel for PTSD, 100% of them financed by pharma. Papers of Seroquel for bipolar depression, 100% of them financed by pharma. JD, 100% financed by AstraZeneca, right? You can't even take that author seriously. Now, the authors of this paper, I only saw serious papers being published by them despite their ties, and I was very confused by it. But once the patents are out, most of the patents are over, they have generics, this comes out. As if, makes me very suspicious. But what I'm trying to tell you is that there is an expansion of, and this is Dr. Sami Timimi. He uses that. He says diagnoses are brands, and you expand them as you can. And part of the population embraces this idea. Used to be that bipolar would only happen in adults. Now we have kids with bipolar, right? Thanks to Dr. Joseph Bitterman and Jules Engst, mostly among others, but I think just in the United States, Joseph Bitterman, rest his soul, was the guy that made the highest impact on bipolarity in childhood. And then we have ADHD. Now, ADHD, if you think about it, it comes with, I hate to say this, but it comes with perks to say, I have ADHD. That's why I'm failing this. That's why I struggle with that. And that's why I need candy. That's why I need a stimulant. So then they expand the ADHD to adulthood. And there's 3 big papers trying to claim there is adult onset ADHD. Even if you didn't have the traits when you were a kid, you may develop them as an adult, which is a little bit of common sense would tell you as an adult it's nearly impossible to focus on anything. You know, you have a married life, you have a kid, and you have a job. What you're going to do? You're going to focus? Sorry, buddy, you're not going to focus. So we have this expansion, and people pursue these things. I see people crying. I had this lady. She comes to me, and she is probably used to the usual shrink, and she tells me this story where she's starting to lose performance everywhere in her life, including professionally. And of course, there's something wrong with me. I read about adult onset ADHD, and I get her story, and I hear. And so far, DSM is not acknowledging adult onset ADHD. It's a matter of time because 100% of the task force works for pharma. So, what I told her was, you don't meet criteria for ADHD. What we find out is that once her son started school and she had to add his homework and school duties to her routine, she started to fall apart. And it was, I'll credit Skinner on that in my initial formation, because I used to be an enthusiastic behaviorist back in the day. But we did a functional analysis of her situation, and what came up was, once she started to have to address his academic needs, the decline started. And the decline was resolved by just delegating that task to her husband. And she comes back with him, and she was crying when I told her, says, it doesn't sound like you have enough reason to take a stimulant, like I wouldn't. So here, this is the situation. So she cries, man. She's like, she's hoping for that thing. And I didn't mean to say sex in the sense of attractive on a dating pool, but in the sense of saying, hey, man, this comes with a lot of perks, and the advertisement for this is amazingly well done. The people advertising for this thing, they're not stupid. They know what they're doing. Go ahead, Andy.
I think something that is related to this and touches on the things that we have talked about already. I want to focus on ADHD for a moment here. And if you go back to 1996, Peter Jensen, who was the chief of child and adolescent psychiatry at NIH, he and some other people published a paper in the American Journal of the Academy of Child Psychiatry Journal of the American Academy of Child Psychiatry. And these are not evolutionary guys. And they publish a paper on ADHD as the response-ready individual, a suite of traits that were selected over time because in ancestral environments they provided adaptive benefit. I think it's a wonderful paper, and again, it shows where, this is laid out by reputable people in child psychiatry. Have any of us heard of the paper, right? And I think it's a tragedy. And they make the case, and what do you see? Look at the description of ADHD. It's the description of somebody who would probably be a good hunter. Why do you see high rates of ADHD in the most successful athletes? Think Michael Phelps, because it's useful. You respond quickly. You jump quickly and ask questions later. Again, I think, obviously I'm biased, but I think that paper should be read by anybody interested in or treating ADHD patients. And I think it would give us pause. And, they make the case that our species is 300,000 years old. The modern classroom's 300 years old. But I want to put that interject that paper and that concept into these discussions, because again, I think it's where psychiatry has ignored an important advance in the theoretical understanding of the etiology of ADHD.
Very good. Would you please email the reference for me later? I would
Absolutely.
really appreciate that. I may end up just making an episode about that. Thank you very much. Now, Paul and Andy, we spoke about what the functions of emotional pain that end up being, and we are not going over, we just now spoke a little bit of ADHD, but we're focusing mostly on depression and anxiety related things. We're not talking about schizophrenia. We're not talking about anything like that. Eventually we should, maybe not probably not today, for sure not today, but the reason I say that is because in psychoanalysis, psychosis is attending to a function, is attending to a purpose. Breaking with reality has a protective role, so to speak. But before going there, before we even extend to that, can we try to word, considering what we spoke about, the importance of pain, what pain does for us, the concerns we have with suppressing that emotional pain with meds, can we try to word what the purpose of psychiatry would be in a world where psychiatry was open to these questionings? Can we try to summarize this thing as a sort of a step towards an end?
Sure, I'm happy to give some preliminary thoughts on this issue. As I said, I think and so I'm going to give you a list of things that I think are important, should be important to psychiatry. One is accurately distinguishing between healthy and unhealthy, normal and pathological, functional and dysfunctional mental states. And where that, I mean, is where something is either working, the nervous system is working the way it evolved to work, or it is not working the way it evolved to work. Just like a heart attack represents a dysfunction in how the heart normally is evolved to work, right? So that applied to issues of pain would be to understand when the nervous system's evolved pain functions are working appropriately and when they are not. Because because even though we focused a lot on how pain is normal, there are lots of normal pain mechanisms in the body. Just like our eyes can malfunction, our hearts can malfunction, our kidneys can malfunction, pancreatic islet cells can malfunction, et cetera, et cetera. Evolved pain mechanisms must malfunction at some rate as well. It's what happens when we get older. All of our evolved adaptations start breaking down at higher rates, especially after the reproductive years. So we believe an evolutionary approach understands that malfunctions in the body must occur at some rate. So even pain mechanisms. So again, crucial to understand when pain mechanisms are working the way they have evolved to function and when they are breaking down in some way. Crucial, fundamental thing. Now, we can also take the perspective that we should reduce suffering. I'm not saying that that's a bad thing to do, but if we borrow from every other field of medicine, the etiology by which that suffering has arisen is crucial to developing effective treatments. So, for instance, if you are dealing with a normal pain response, right, the primary goal ought not to be probably with some caveats, because again, I know I sometimes use some pain medication to alleviate some of my suffering too. I'm not saying that that's completely irrational, but nevertheless, that whether or not the pain mechanism is working the way it's supposed to work, or whether it is dysfunctioning or malfunctioning, will inform treatment. As an analogy, right? If we think about, you're a physician, a patient comes to you with an elevated core body temperature, they have a fever, right? Should it matter to you whether or not that patient is having a normal response to an infection, or is having an adverse drug reaction, or has a tumor that's causing the elevated core body temperature, or has a genetic disorder? Those are all actually 4 different, possibilities for why a patient could come in with an elevated core body temperature, fever. But of course, understanding which of those possibilities is the actual truth for your patient is crucial to understanding how best to treat, right? And again, that happens in every other field of medicine, and we've already talked about how it's not happening in psychiatry, and it's because we have this seductive red herring view that we should just be worried about reducing suffering, but it gives us a pass on not thinking about etiology. So I think if we have that clear understanding that we must figure out how pain mechanisms evolve to function, we'll have a better idea when they are malfunctioning, and figuring out why a patient is coming to you for some distress, whether it's a normal functioning pain mechanism, where it's a malfunctioning pain mechanism, will be crucially important to improving treatment for our patients. Anyway, that, and what would you do? Like, you have a patient who's got, depression, is coming to you with depression, Well, one of the things that Andy told me he did after we started working together is, since we have a good argument that most depressions, socially triggered depressions, are really the result of your brain trying to muster all of its intellectual powers to help you solve a really complicated problem. You and I both know, all of us here know, your audience will know, that some patients are going to be more self-aware about what they do, about what's going on in their lives, than others. Well, one of Andy's things that he does is he says, first thing is, he asks his patient, what are you ruminating about? I mean, you could ask, what is going on in your life? And sometimes you'll get people who are really self-aware, and they'll be able to provide an answer. But sometimes they won't. So getting at the question differently is, what are you ruminating about? What are you thinking about? That may help get at the same issue from a different angle, right? It forces them to acknowledge what's going on in their brain, even if they are trying to dismiss all of the complex social stuff that's going on in their lives. So that's one way in which, understanding depression as a normal cognitive response would affect treatment. As we've talked about in our Disordered Doctors paper, most psychotherapies actually require the brain to be working quite well. It's easiest to talk about that with respect to cognitive behavioral therapy, because it's based on the idea of the therapist is not there to provide answers for the patient, but to actually get the patient to think through their own situation by using Socratic questioning, and then to encourage the patient to develop and test hypotheses about what's going on in their lives, in particular in their cognitions. And okay, so Socratic questioning, that's stuff that's used in law school and stuff, right? It's in philosophy. You need a brain that's working well to be able to to handle Socratic questioning. And of course, hypothesis testing it's the foundation of science. So again, that also requires a highly functional brain. So if you've got a normally functioning brain, if we were conceiving of, if you can tell that a patient is having a normal pain response, something like a psychotherapy like CBT might be the most appropriate thing to do. The disorder narrative doesn't actually work well with a psychotherapeutic approach. And I've tried to convince some of my clinical psychology colleagues that they ought to care about the disorder narrative because it doesn't work well with the psychotherapy. I mean, how would you expect somebody with a malfunctioning brain to be able to handle Socratic questioning and do hypothesis generation and hypothesis testing? You wouldn't normally expect that. On the other hand, the disorder narrative does work well for things like antidepressants and ECT and other things. They are under antidepressants and ECT are all sort of based on the idea that something is not working right in the brain. And so in principle, the ECT or the antidepressant is an intervention that could, at least in theory, help solve some of the problems that are going on in the brain. So, whether or not accurately distinguishing between depression as a normal emotional response to problems of life versus something that's going wrong in the brain, already we should have a clear understanding that has different implications for whether psychotherapy or medications are given. And but I don't see that being acknowledged within the field. I mean, you have clinical psychologists buying into the disorder narrative, and arguably that may help explain why psychotherapies as a prescribed treatment, I suppose, has declined since the 80s, and antidepressants have risen. So I think that we can lay the decline in psychotherapy and the rise in antidepressant back at the feet of the DSM-3, which starts, essentially saying that if you meet these particular symptom cluster and have some impairment or distress, well, that's enough to say that you've got a disorder, and that's why antidepressants have risen in such dramatic fashion in frequency over time.
Thank you very much, Andy. Any thoughts?
Yeah, I want to go back to Paul's analogy, which I think is beautiful. What would all of us think about a physician who had a patient, and the patient kept coming in and said every 3 or 4 days or every week they're spiking a fever? And the physician just gives them Tylenol and sends them on their way. And they come back a couple weeks, they're still having these recurrent fevers, and they say, oh, well, the Tylenol doesn't seem to be working, and so they give them Advil. And they go off for a couple weeks, and they come back, and they're still having fevers, and they say, well, I guess the Tylenol's not working, the Advil's not working, okay, let's try aspirin. And the physician diagnoses the person with major fever recurrent, moderate, and is trying one antipyretic after another. So 6 weeks down the road, they come in, they're still having fever, and they've been through Tylenol, Advil, aspirin, naproxen. And so now the physician says, well, I guess the person has major fever recurrent and now seems to have developed treatment-resistant fever. And the physician has done nothing to try to determine the etiology of the fever. What would we think about that physician? If we were talking to the patient, we would probably say, you need to see somebody else and you need to go to a malpractice lawyer. Because that physician has been grossly, we laugh about it, but that physician that's a clear failure of standard of practice in medicine. And the standard of practice is that you search for etiology. Okay, and you know, my profession, more often than not these days, is basically practicing like that physician who's diagnosing major fever recurrent and just giving, you know, multiple drugs and then calling the person treatment resistant if they don't get better, and not looking for and making a serious effort at etiology, I mean, to find the etiology. And even if, let's keep on that analogy, and even if we can't find an etiology and we diagnose the patient with fever of unknown origin, we are still seeing that patient as having a problem, and we don't know the etiology. We're acknowledging our ignorance of the etiology, and we have tried our best to uncover, but we're going to watch that patient carefully to see if the etiology will ever show its face, right? And I think, to get to your question about the purpose of psychiatry, again, is the purpose is to find the etiology, the causes of emotional suffering, and to be honest about it. And my bias is, and if those etiologies are tied up with evolution and the evolution of certain adaptations, to be honest about it, and also to be honest about our ignorance, and to base our treatments on that. But that's not what we're doing these days. We pretend to know the origin of depression, and we see it as a disorder, and it's a disordered brain, even though psychiatry has yet to produce a model, a theoretical model of depression that is supported at every level, from, you know, molecules to minds. But we pretend as if we have that, and we treat it and feel like we're in the right. And I think that's unfortunately dangerous, and I don't think it's far off from the analogy of the physician who is treating a fever and never pursuing the etiology.
Absolutely. What I'm hearing, and it's going to take a while for me, probably I'll have to add it to the episode and then listen to this. I'm hearing a stratified sort of a purpose for the field, where we establish etiology, and then, you know, more philosophical or personal questions from a clinical perspective. That's pretty much what matters for me. Go ahead.
I just had a thought. I want to add it.
Please add,
Okay.
Andy. Go.
So you've seen it, and I think Paul has seen it too. Psychiatry now, you know, prides itself as having moved to become more of a medical specialty. You know, we got away from Freud and we became neuroscience, and we became more of a medical specialty, right? And we take pride in that. But if you look closely, we really haven't, because, as Paul pointed out, what's true in the rest of medicine? There's a relentless pursuit for etiology, and seeing symptoms as signaling that there's a problem, and going after etiology. And the reality is, we have not become like the rest of medicine. And we don't want to. I think it's a little bit of a professional self-deception. You know, we're now real doctors, neuroscientists. We're now back the medical model. We're now practicing medicine, and got away from Freud and all the crazy psychology stuff. But the reality is, we are not back to practicing in line with, you know, the purpose of medicine as you all have laid out.
It's impressive that even if you are thinking of diabetes, a doctor diagnosing diabetes is going to have more, he's going to attribute to diabetes to more external factors like eating habits, lifestyle. If you have someone with, we were talking about our different, I was mentioning that Andy has a wonderful tan, and he avoids sun, and I expose myself and I look like a plastered skin. Alabaster. Okay. So, and we're talking about skin and sort of, sun-related stuff. And even a dermatologist is going to have more freedom attributing skin lesions to external factors, to your genes. And we in psychiatry, we just don't look outside of the body. We decided that there's something wrong in the brain,
Right.
and he dies there. He dies there,
Right.
despite
Well,
100 years of production in sense. In
right.
that sense.
Well, let's run with your diabetes analogy. Paul and I were preparing last night, and we I think talked about this, or I put it in an email. What would you say about the physician who's treating a diabetic patient and is just constantly adjusting the insulin, and never asks the patient about their diet, and finds out that this diabetic is, every night he's, loading in the brownies and ice cream, and never asks about that. And then the patient, and this is based on an actual real case, of an older man I knew who had diabetes, and he would get frustrated with the management, and probably about once a month he would get annoyed, and he would drink to excess, and or have a lot of dessert, and he would go into full-blown hyperglycemia and ketoacidosis, and his wife would mercifully saved his life a couple times, got him to an emergency room, and saved his life a couple times. But what would you say about a physician that was just tweaking with his insulin and never asking about his diet, and trying to find out the causes of his recurrent hyperglycemic ketoacidotic crises, and just diagnosed him as recurrent ketoacidosis major, and never pursued the etiology?
Very good. Again, Andy, Paul, guys, thank you for your time. Thank you for your patience and your willingness and passion, I would say, to try to make a dent in our beloved field of psychiatry that has been for sale for a while. So let's see what we can do in that regard. It's not an easy task. And please, let's keep in touch. I'm sure that as we progress, new thoughts will come up. My personal interest with this is to have these answers in a way that can guide the work of people out there seeing patients. And so this is really, really priceless. Thank you, guys.
Thank you for the opportunity.
Thank you.